The respiratory tree is divided into a conducting zone and a respiratory zone. The conducting zone has large airways which consists of the nose, pharynx, trachea, larynx and bronchi. Airway resistance is highest in the large to medium sized bronchi. Small airways consist of bronchioles that further divide into the terminal bronchioles. Large numbers in parallel means least airway resistance. The conducting zone warms, humidifies, and filters air but does not participate in gas exchange. It is called as an anatomic dead space. Cartilage and goblet cells extends to the end of bronchi. Pseudostratified ciliated columnar cells primarily make up the epithelium of bronchus and extends to the beginning of terminal bronchioles. Then they transition into cuboidal cells. What we are seeing here is the same. Pseudostratified ciliated epithelium, simple ciliated columnar epithelium, then the transition into cuboidal cells. They clear mucus and debris from the lungs. It is also called as the mucociliary escalator. Airway smooth muscle cells extends to the end of terminal bronchioles and sparse beyond this point. Here we are looking at the smooth muscles till the terminal bronchioles. Then coming to the respiratory zone. The respiratory zone, the lung parenchyma, consists of respiratory bronchioles, alveolar ducts and alveoli. It participates in gas exchange. The cells are mostly cuboidal cells in respiratory bronchioles, then simple squamous cells up to alveoli. Cilia terminates in the respiratory bronchiole. Alveolar macrophages clear debris and participates in the immune response. So we are seeing the cuboidal cells up to the respiratory bronchioles, and here are the alveolar cells, alveolar macrophages. Next page, coming to the lung anatomy. Right lung has 3 lobes, left has less lobes, that is it has 2 lobes and a lingula, so which is the homologue of the right middle lobe. Instead of a middle lobe, the left lung has a space which is occupied by the heart. It is shown by this figure. X-ray shows here. And the relationship of the pulmonary artery to the bronchus at each lung hilum is described as RALS, R-A-L-S. It is right anterior and left superior. So carina is posterior to the ascending aorta and the anterior medial to the descending aorta. This is the carina, the aorta, anterior is the ascending aorta, and here towards the medial side, anterior medial is the descending aorta. So right lung is a more common site for inhaled foreign bodies because the right main stem bronchus is wider, more vertical and shorter than the left. So if you aspirate a peanut while you are in supine position, it usually enters the superior segment of right lower lobe or sometimes enters the posterior segment of the right upper lobe. While lying on the right side or prone, it usually enters the right upper lobe. While you are upright, usually enters the right lower lobe. Coming to the diaphragmatic structures. So the structures which are perforating the diaphragm, we have at T8 the inferior vena cava and the right phrenic nerve, at T10 esophagus and vagus, at T12 aortic thoracic duct and the azygous vein. So diaphragm is innervated by C3 to C5 phrenic nerve, and pain from the diaphragm irritation can be referred to the shoulder and the trapezius ridge. The shoulder because of its innervation by C5 and trapezius ridge C3, C4 is in common innervation. Phrenic nerve injury causes elevation of the ipsilateral hemidiaphragm on X-ray. So the mnemonic to remember the innervation of the diaphragm, it is number of letters is equal to the T level. So T8 is vena cava has 8 letters, so it is at the level of T8. Esophagus has 10 letters, so it is at the level of T10. Aortic hiatus has 12 letters and it is at the level of T12. So I 8, 10, X at 12. Other bifurcations are The common carotid bifurcates at C4, the trachea bifurcates at T4, the abdominal aorta bifurcates at C4. That's we come to the end of respiratory anatomy.